much for inviting me. I will say something now and I'll say it again at the end, which is, it's not that this was my background. My background really wasn't about intestinal rehabilitation, but one of the neonatologists or hospitalists needs to take it on. And I think that that would add such a great deal to what you've just presented. We call it NeoChirp. You can call it NeoMerp. Feel free. But I'll talk to you some of the things that I will present. Maybe a little bit of what has been said. I'll go over that quickly. But a lot will be on very practical terms and in relation to the NICU. I have no conflicts of interests or conflicts of commitment to resolve. The objectives I see are to identify the advantages of an intestinal failure team in terms of helping you to understand the anticipated hospital course, considering the intestinal anatomy and the function, to provide a consistent approach and to focus on growth and nutrition. And there I might be a little bit cautious about the advantages of getting off of TPN as if that was the goal. The goal really is growth and nutrition, and which you probably experience that as those two things going together, but sometimes we have to be careful on that, and to discuss potential disadvantages of starting a new team. So definitions was already mentioned, a reduction of the functional gut mass below a minimum need to absorb nutrients and fluids required for adequate growth. So that's where it's different in the pediatric population than in the adult population. They don't talk about growth, they talk more about maintenance. And though Fullerton is talking about parenteral nutrition need for greater than 90 days. Paul Wales would go with your definition of greater than 42 days after bowel resection, still requiring parenteral nutrition, or small bowel length less than 25% of expected. So as far as how long is the small bowel, in the term infant, you expected about, hard to tell on postmortem, but basically about 250 centimeters of small intestine and about 50 centimeters of colon. So an important thing that we look at is 10% of normal small bowel length is equal to gestational age minus 10 centimeters. So if you're talking about a 23-weeker, 13 centimeters would be about 10%. So less than 13 centimeters, and where we look at it is from the ligament of Treitz, so the jejunum to the ileocecal valve, so you're talking about the jejunum and the ileum. And less than 10% of expected small bowel length is associated with increased mortality. But again, as was mentioned, I don't know if today people are talking about how short is too short anymore. Preterms between 30 and 40 weeks, as mentioned, you have huge lengthening. Then it's by about 150%, and it nearly doubles by 18 months. So there's a lot of potential in the neonate. Tell you a story of Emma. 27, this is a typical baby that we would see. 27 and 6 weeks, antenatal history of an umbilical vein thrombus. Mild RDS on non-invasive ventilation. Day 2 of life, had donor breast milk, HMF added. Day 7, day 8, feeding intolerance. Otherwise, the baby looked quite well. The baby was placed NPO, and the next day was found to have some abdominal distension, and on x-ray found to have perforated neck, went to laparotomy. This was a picture of her intestine, and there was 57 centimeters from the ligament of Treitz to the stoma, and an extra 21 centimeters from the mucous fistula to the ileocecal valve. So had a jejunostomy and a mucous fistula, and this was extremely important for us to know what's happening. So we have pictures on all of our I don't know if you do here, probably you do, but there are pictures for our babies so that we know exactly what was done and how much functional gut there is. how much length of gut there is. So for me, as a neonatologist, essential surgical information, the diagnosis, the amount of bowel resected, what it looked like, the length of bowel from the ligament of Treitz, which in a gastroschisis there isn't, because it's all the bowels kind of around. You don't have a ligament of Treitz to measure it by, and if you have a lot of matting, you really can't tell how much is there, but surgeons can often tell us if there's adequate, adequate amount of bowel. Looks like the length is there, and the condition of the remaining bowel documented with a picture. So for us, from the medical side, both in terms of in the nursery and subsequently, you want to know where are nutrients absorbed. So what's taken out, where are the nutrients absorbed, and what kind of concerns do you have right now, as well as what would we recommend, because here, as well as in British Columbia, there's a huge geographical area. So we're often sending babies back to family physicians up in northern British Columbia who really don't know about any of these diseases in as much detail as you might need in order to follow these guys. So if you're saying that B12 is extremely important, maybe they'd know that, but we have to actually say, not that the baby had surgery, but what is the terminal ileum there or not? Those kind of things in order to help long-term, as well as short-term, where are you expecting, are there going to be problems with feeding a baby? And what kind of problems might you run into? So we look at the post-op clinical course in 3 stages. There's the acute, recovery stage, and maintenance. Acute is initially right after the initial ileus is finished. So it's initially, but not immediately, but it's in the first few weeks. You have a delayed transit time. There is an ileus, takes a while. You may have gastric hypersecretion. Large fluid and electrolyte losses may then come from the ostomy. And the goal of that stage is nutritional support. So you start TPN immediately. And then the recovery stage could be weeks to months, where you may have diarrhea, you may have decreased ostomy outputs. The priority is to optimize enteral and parenteral protein, energy, nutrition, and the micronutrients. So we start to increase enteral feeding, oral stimulation, because we're very concerned about oral aversion in our babies. And it's really a difficulty that we've run into, and I don't know if you do here as well, but especially in the neonatal intensive care unit, we're so used to what's your TFI, what is the total fluid intake, that people have a tendency to say, okay, if you're going up 1 on enteral, you go down 1 on TPN. And we have to, in babies who do not have cardiorespiratory concerns, we're not concerned about fluids and electrolytes. We want to see growth. I want to see if a baby is starting to cross centile lines on their growth charts, then they're probably getting too much. But just going up and using your cap being the TFI, I don't think serves them well nutritionally. Maintenance stage is up to 18 months. And then you're going to get growth in your crypts and your villi, and you're going to have improved function. You're going to have, if the ileum will take over much more readily than the jejunum as far as function. So you're going to have a lot of changes and improved absorption coming on, but it takes time. And the goal, again, is optimizing growth. Enteral autonomy may not be achieved right away. It takes time. That's why there's a home parenteral nutrition team. And babies go home. So you wean the PN, monitor transit time of the gut, and see how the baby is doing. So here's my plug on the multidisciplinary intestinal failure team. I put neonatology on top just because they start in the neonatal intensive care unit. In our emporium in BC, neonatology started this because we saw that these babies, you had surgery, don't take offense here. Surgery would come in because they come in at 6:30 in the morning or 7 o'clock, and they start to write orders to, the fellow comes in and says, go up on the feeds, and then as the day progressed, we'd end up with a clinical associate or somebody on at night who wasn't necessarily part of the team, and the nurse would say, oh, the baby's really not tolerating, and they'd stop the feeds. And then the next morning, we'd be up and down, and our babies really weren't doing well, let alone the parents were going crazy because everybody was changing every time, and every time the service changed, there was another neonatologist with another brilliant idea, and the parents would say, that was tried 2 weeks ago. But they wouldn't really tell us because they would feel uncomfortable telling you what you should be doing in your job. It was a problem, and I believe that some of the babies really were adversely impacted by these changes. So surgery is important, our dietitians, the bedside team, so that they all know what's happening, which includes the parents. And GI, or in our center, we have a pediatrician her area is intestinal failure, specifically. Pharmacy, and in some centers they have OT or speech therapy also involved, and we sometimes get OT to come on rounds, but that isn't a regular part of our round. As far as outcomes, Dave Sigalet did this study some time ago in Calgary, and he found that went from, just quickly, 72% survival in the earlier epoch to 100% survival. So, and other centers are finding that. Furtado in Montreal also found great improvement pre and post having an intestinal failure team. However, it is an inexact science. And this is, it feels like it's more expert opinion often, as the earlier talk by Richard, that it is expert opinion. We don't have a lot of the information we do, and certainly not necessarily for the individual patient. So when to feed, enteral feeds, very important because of release of GI hormones, peptides, benefits to the enteric flora, as well as the immunological benefits of breast milk, mother's own breast milk particularly. Trophic feeds as soon as possible after post-op ileus. And, you know, obviously it's in consultation with the surgeon. There are some people who recommend very, very early feeds, and sometimes some of these babies take a very long time till you're not getting bilious aspirates. It doesn't make sense at some level that we say, hold it, if it's not actually going, if it's going antegrade, you're not really, what are you doing putting something in if everything else is coming out? But there was another Turkish study that they started feeds extremely early, day 1, day 2 as well. I think it was day 2 in that study. And again, it's kind of like the earlier presentation about the fish jumping out of the fishbowl into another one. We have to think about these things. We've always done it a certain way. Does that mean that's the right way? I'm not sure. What to feed, mother's own milk, obviously, as mentioned, because of immunological benefits as well as growth factors. And we do have a milk bank in Vancouver. It's one of the longest running ones in North America, but it's a substitute. It is not as good as mother's own milk. And so one of the problems I'm experiencing is when you have a donor bank, it's great, but then people start to think it is the right thing to do. So, you know, the mother just had a baby. She should rest a little. So that people aren't saying, okay, that means you're going to start hand expressing immediately. They've had very good results in the UK by doing that kind of, even starting to hand express before delivery. So starting things very early and getting regular hand expressions for first 24 hours is what we recommend, and then pumping, and that means getting up during the night and pumping and getting that going, because mother's own is going to be the best that we can provide, and we sometimes miss that piece. So that's one of the disadvantages of having a readily available donor bank. Formulas, if you need a formula, again, this goes, what was mentioned earlier, that there are changes. We used to, with our intestinal failure babies, start on an amino acid-based formula immediately. We didn't start on donor milk or breast milk or another formula. And that has changed so that we very rarely recommend a formula unless there obviously is a very short intestine and a huge amount of output. But it's not so things do change even in a short period of time as far as what we think is the best way to go, and it will change some more. But there are at this point, we're saying if you're going to go to a formula, we usually start with donor, and then if the mother cannot pump and cannot breastfeed for whatever reason or does not wish to, we would start with, and if they don't want donor, we would go to a formula, otherwise donor milk until they get onto full feeds, and then start with a formula. Routes of feeding. In North America, we recommend most people recommend continuous feeds, realizing that it's not completely continuous, because if you're going into the stomach, there is a pyloric valve there. So it's not going to, unless you go transpylorically, you're not going to have continuous feeds. They're going to be in boluses that the baby will make sure themselves. But the advantage is potentially maximally saturating the gut transporter carrier protein, and continuous feeds improves the length of the crypts and the villi. Bolus feeds in Europe is more, Goulet writes about this more, and feels it's more appropriate, more natural way to stimulate enteral hormones. Gastric is more physiological than jejunal feeds. Oral feeding, important to preserve oral feeding skills. Feeding, it's oral aversion is common, so we do want to get babies onto some oral feeds, which we do when they're getting at least 5 cc's, starting continuously, and then getting up to, we'll start at 1 ml per hour, and then work up daily till about 5 mLs, and then go to at least once a shift or once a day, having the whole 5 mLs as a bolus. It's felt to actually improve a lot of the feeding that the baby needs to do, but occasionally you get huge amounts of stool output or stomal output, and then it just isn't, you have to go slowly at this. So important to monitor fluids and electrolytes, and then we go to a pumped or a partially pumped breast. I'm never sure when we say to mums that they know really what we're talking about, but we tell them to do that. So important to avoid creating oral aversion. Sometimes the babies usually know what to do even without us. So feeding tolerance. Stomal losses, we usually accept up to 40 to 50 mLs per kilo per day. It's not just the absolute amount, but how quickly, if we've gone from the baby was putting out maybe 15 to 20, and then all of a sudden it goes up to 40 to 50, that's probably too much. So we have to pull back. They're going to run into fluid and electrolyte problems. They're going to run into potentially pH, acid-base intolerance, and it means the baby isn't tolerating it, so we pull back. That doesn't mean stopping feeds. It just means pulling back to the last time when you had increased it. Maybe leave it there for a little while and then go up. Stools, important to watch losses, baby's weight. We watch all anthropometrics. We have been trying, and I'm not sure not fully successfully, but we've been trying to get something called Measure Me Monday. That means all babies get full anthropometrics once a week. And it's hard. You have to talk to the RTs, and when they're taking off any kind of headgear, CPAP, whatever, that's when you're going to measure the head circumference. But it means that we're regularly watching length, head circumference, and weight. Weight is not a problem. Everybody measures that regularly. It's the other anthropometrics that people find difficulty just actually operationalizing. Vomiting, small volume intermittent regurg may be fine, but in a clinically well baby, but significant regurgitation, even in a clinically well baby, may be the limit of their tolerance. Again, going back to what's the anatomy, at least so that we know what do you expect. So I'll tell you a story of Leo. Leo was born to a 30-year-old gravida 2. She had a previous 26-week male infant. She had a bicornuate uterus, and that baby had a grade 3 IVH and at 3 years was doing brilliantly well. Very healthy. So she then came into labor very quickly at 24 and 2 weeks. The baby was LGA. There was some polyhydramnios. And the baby, there wasn't enough time for antenatal steroids. And the baby had a moderate RDS, was on a ventilator, got surfactant, prophylactic indomethacin, was doing actually quite well for the first few days, had to rule out sepsis with antibiotics for 48 hours. And day 1 started on trophic feeds, expressed breast milk, increased 20 mLs per kilo per day. Day 4, found to have bilateral grade 2 IVH. Day 6, respiratory deterioration, large PDA, started on indomethacin. And day 9, there was some abdominal distension. The baby was thought to be septic, hypotensive, acidotic, and there was some evidence of renal failure, started on triple antibiotics. And day 11, now corrected age 25 plus 6 weeks, bedside lap. They removed 50 centimeters of small bowel. So remember what we said about what's 10% was about 10 centimeters less than gestational age. At this 25 weeks, nearly 26 weeks, we're talking about 15 centimeters you would need. And this baby did have, in total, enough bowel, but there was about 6 from the ligament of Treitz, there was about 6 centimeters of jejunum, and then the end was sewn over, and it was basically dropped back into the peritoneal cavity. And then beyond that, there was a mucus fistula. Beyond that, there was 13.5, and then there was an anastomosis and 8 centimeters to the terminal ileum. So there should have been enough bowel here, 27 centimeters, and you're talking about 25 weeks, so it should be, and the full length of colon. So predictors of intestinal autonomy, absolute residual length is no longer thought to predict adaptation. And as I mentioned, this 10% of normal length, gestational age minus 10 centimeters. Intestinal capacity for adaptation, the ileum greater than the jejunum. The key to intestinal autonomy is introducing enteral nutrition as soon as possible, stimulate intestinal adaptation, preserve mucosal integrity, decrease bacterial translocation and sepsis, decrease parenteral nutrition-associated liver disease. But with significant intestinal failure, it may take 2 to 3 years or longer for intestinal autonomy. Even if absorbing calories after PN may become deficient in other electrolytes, micronutrients, especially fat-soluble vitamins, depending on what's available in the ileum, zinc, calcium, magnesium, B12, so be prepared for the marathon. And some of these losses, as long as you're on parenteral nutrition, you're getting all of your trace elements and you're getting your micronutrients, but it's when you come off of it that you might run into problems, and you may not see it right initially. Depends on how old the baby was, what the reserves are, but you might run into significant problems down the line. So, does an intestinal failure team work? We did a study looking at gastroschisis just because that was easier with CAPSNet to get that database as far as gastroschisis was an identified that was an identified disease. And we looked at team centers across Canada with no team and a team. Primary results, in fact, when there was a team with low-risk patients, there were more parenteral nutrition days. Secondary results, there was a longer length of stay, longer ventilator days in the low-risk team patients. So that didn't exactly make sense, except that what we were doing when we started a new intestinal failure program is we had protocols and everybody was treated the same. So gastroschisis, you get this. Everyone gets that. So we found that the patients who were really low risk, who did well, hadn't been individualized, and so we were ending up maybe doing them a disservice. However, the high-risk group, there was increased mortality in the no team group, 28% versus 9% in the team group. So you have, what we learned from that is we have to individualize it. Then we looked at another study we did was looking at the impact of a complex nutrition team, which is what we called ourselves at the time, on the healthcare team. That's where my ethics comes back in here. And we wanted to examine the perceptions of the NICU healthcare providers regarding the usefulness of a multidisciplinary team for the management of patients at risk for intestinal failure. And we didn't get babies, only babies that we thought for sure were going to have intestinal failure. We look at all babies who have had small intestinal injury, surgery, that we don't limit ourselves. So we start with that, and then they will graduate out of the NeoCHIRP program. And we wanted to see how we could improve things. So we started doing weekly rounds in the NICU in May of 2007. And we'd been going about this for about 5 or 6 years, 7 years. And then we decided we should really look at how people are appreciating this or not appreciating this. Because I got some negative comments, like Tuesdays is the day that we meet with our surgeons to kind of go over what's our patients that we have in common, what the plans are. And then we had on Tuesdays also the complex nutrition team rounds, and my colleagues were calling them terrible Tuesdays. So that went right after Measure Me Mondays. It's interesting, nutrition is a bit different, I believe, than something like a ventilator. There's a ventilator group that looks at, you have a meeting, and they look at a new ventilator, and they say, we should bring this in, and everybody goes, okay, fine, yeah, we'll try that. Nutrition, we all eat, and so people are very offended when I'm telling you how to manage a patient as far as nutrition. There seem to be, it's just a very, it's a very basic thing as humans that we know about nutrition, and don't tell me what to do about it. So there was a bit of anger from some of my colleagues, and there also was a bit of resentment, I think, from the nursing staff, because we kind of came in and told them what to do, but they weren't really a part of it. So those are concerns that you might have. So we looked at focus groups to discuss healthcare providers' experience in 2014, 2015, and to understand their base knowledge, understanding, and attitudes towards this team, usefulness, educational opportunities and improvements. And the focus groups discussed, there were discussions, they were discipline-specific, and they were audio recorded, anonymized, and transcribed, and the transcripts were reviewed by 3 independent researchers and discussed until consensus of the final themes. So there were 146 nurses, which was 67% of our nursing staff at the time, 9 neonatologists, which was 90% at the time, 5 surgeons, 5 fellows, 83%, and 2 clinical associates. Our hospitalists, we find it somewhat difficult to get a time that we can find them because they come in for shifts mostly, and 4 members of the team. And there were several opportunities for improvements. So one of the neonatologists said, some of us were here before the CNT, we now have consistency and we have a plan. And one of the nurses said, the parents appreciate the continuity of care that it provides. So it provided continuity of care, but some of the staff didn't think that we had enough communication as far as the plans. And that's what you were identifying, the importance of that. So the mandate of the team, one of the surgeons said it's modernized care because now it's collaborative as opposed to ad hoc practice. And one of the nurses said it's still a bit unclear about criteria that babies have to meet to be part of CNT. And another nurse said it's confusing because we started in 2007, and in 2011, 2012, there was a new team started about our complex babies. So then, was it complex nutrition or complex? And they got so, they didn't know which rounds were happening at that time, and so we changed our name to NeoChirp. So that it had some, because the pediatric side of things is the CHIRP, the Children's Intestinal Rehab Program, and we just were the neonatal side of that. But it was confusing. Just the name itself got people a little frustrated and like, what am I supposed to be presenting here? Am I doing regular rounds on complex babies? What am I presenting here as far as from the nursing staff? Format of rounds. One of the pediatricians, who's the hospitalist, said, I would like to see their standard Tuesday afternoon, make a plan, and maybe have a Friday check-in, because it felt like coming in once a week wasn't enough. They needed to know how to access us besides that. And one of the nurses mentioned this, but several were really in agreement with, usually the nurse is on lunch break. When are you doing these rounds? We're on breaks. And to me, that identified both that they're not getting enough out of it. So you're not planning your breaks around it, or we're not clear enough as to when we're coming to each baby. So it makes it very frustrating and makes it very difficult. So staff needs to know who to contact, and we continually revisit the timing of rounds and plan breaks in advance, and we're still working on that. Communication. One of the nurses said, if you're not there, things are happening behind your back. And she was quite angry about this. It felt like they were not part of this. And then somebody, we had a sheet that we put up on the wall which had the plans for the week. And one of the nurses said, there's this phantom group that goes around and puts up these yellow pages. So it felt like we were dictating what happened, and it wasn't being communicated well enough. And at the time we had one dietitian, and it was difficult for her to then go back and talk to the nurse and make sure they knew everything that was happening. So communication is a big piece to be sure about. Information, one of the fellows said, I want to see not only the orders, but the rationale behind them. We now have, in the charts, definitely, number one, it continues to say, what are the baby's problems from an intestinal standpoint? A picture of the surgical, the most recent surgery and what's available in the gut. And also, as far as the nutrition, what's the baby getting enterally, parenterally, growth, lab work, and then at the end, just an assessment of that and plans. So some babies have, like Leo that I mentioned, had so little, you were never going to get to enteral autonomy. You were never going to feed that baby in order to get absorption, because the end is sitting in the peritoneum, and it's only 6 centimeters. But what you were going to do maybe is educate people as to this is what's happening. So this is what to expect, and this is what our plans are. When is surgery planned for to reanastomose, things like that. In summary, the intestinal failure teams improve outcomes. They provide an overview of the anticipated NICU course based on functional anatomy, and through a multidisciplinary expertise provide advice for a consistent approach to management of the individual baby. provide a focused approach to growth and nutrition, including starting enteral nutrition as soon as possible. And I can assure you, I'm really interested in nutrition, but when I'm on rounds with the hat of the neonatologist, that isn't my focus. So it provides somebody to step back and really look at that piece separately, which is really, I mean, I look at it, but not the same way, I know. But beware of developing too strict guidelines that may not fit the individual baby, and ensure collaboration and education of the clinical team. Your thoughts? Thank you.
Thank you, Susan, for that presentation. In the adult world, there's a trend for enhanced recovery after surgery, ERAS, where people undergoing surgery are prepared in clinic, even before they come to the hospital, that as soon as they have their surgery, the day off, they're going to be taken out of bed. They preferably have to walk around, and they're going to be challenged to eat or drink something just to improve recovery after the surgery. Do you know if there's any movement in neonatology to think along those lines? Because that would probably indicate that we'd have to approach the mothers when they're diagnosed or pregnant and talk about these things.
I think it's a bit more difficult in the neonatal setting, because antenatal consults, which we do for most commonly gastroschisis, not neck, but or if we think that there's some other intestinal problem, it's really only gastroschisis is the big one that we will know about antenatally, and you can give some counseling, but it's such a wide range as far as how the baby's going to be and what to expect. So I think that it's a bit more difficult, but it's a good thought how we can do that. Do you have any thoughts of what?
Not yet, but I know they're talking about like a children's surgery to start a similar kind of movement. But I was just thinking along the lines, as you said, well, we're going by bilious aspirates, right? But maybe we could challenge that a little bit more, but that requires a change in the culture of thinking that we might have to go against those thoughts. That would not be just the parents, but also the nursing staff, the neonatologist, and that there might be a possible influence of challenging some of these things, but that would be a culture change. So,
yeah, there are big culture changes, and as was mentioned, we are changing all the time.
Yeah.
So we were very concerned about small bowel bacterial overgrowth, and it was a real big push to use cycling antibiotics enterally. Now I'm seeing people kind of stepping away from that, not thinking it's such a big deal. And so I'm really seeing there's phases in which we think something is the right thing. There just isn't the data to support it well enough, so it's the art.
Thank you so much, Susan. I have so many questions I'd love to pick your brain on, but I was wondering, for one of the barriers you mentioned was communication, which is something we hope that the team, like creating this multidisciplinary team, would help with, but recognizing many people might find it challenging to make one meeting once a week at a specified time. Did you have any ideas or ways that you guys overcame barriers, particularly, say, for nursing staff or the bedside nurses, because they're so busy with, trying to provide the care for patients in the middle, but they're also the ones who are carrying out a lot of these plans, and if they don't get to be involved in those discussions, I find we miss a big piece there.
So I think that it is a big concern, and the bigger the unit, the more difficult that becomes, because you have staff changing over all the time. You need champions. You need a neonatologist champion. You need some nurse champions that are going to say, oh, it's too, and you need to have really good rapport with the dietitian that comes around and reminds people, okay, it's Tuesday today. can we plan breaks accordingly? And we will be there at which time works for, so trying to engage people and get their buy-in and include them. And what we haven't developed yet is what the nurses, what's their job during rounds? Because what ends up happening is maybe a fellow, and it's hard for me to get our fellows also involved, but the best would be one of the fellows presents it, not the dietitian, that the fellow presents it because they're learning about nutrition, and there's no other place during their training that they really get that kind of regular thinking through the nutrition aspect. Get the nurse to have, what does she say? What's her part? When is, and I've tried to put in kind of prompts in what is happening, but I feel like I'm kind of watching and making sure, okay, where's the nurse, and where are the parents, and make sure to ask this person. So I'm sometimes not concentrating on the baby as much as I'm trying to get all the pieces. And this is 10 years out. I think having a role, what are people's roles? Because it's different from regular rounds. They're not going to stand there with their sheet and give you the regular rounds thing. This is a different thing. So how do we give people important roles that they're like, how is the baby tolerating feeds? What's happening? And also today, when parents are much more involved in these rounds, what's their role? Even standing there, they're particularly interested in their baby. But figuring out how everybody is going to be incorporated into this team approach is important. We'll talk.
Thanks so very much, Susan. That's a lot of wisdom there.